to distance. Number one thing about these lenses is distance vision. And for me, anything up close is gravy. But this has to be, first and foremost, a good lens for distance. And it's been shown to have contrast sensitivity comparable to the single vision lens. And it has a couple of things that I'm going to mention about optical quality. And this is all about toric lenses. Next slide. I put this slide up. It's a busy slide, but there's a couple of things between the active focus lens and the Symphony. And I know there are several doctors here that prefer the Symphony. I've put a lot of the Symphony lenses. It's still a great lens, but there's a couple things that I like about this lens. First thing, the center portion, as I mentioned, is distance. The Symphony, it's intermediate vision. The next thing is, we have these steps in the lenses. They're called an apodized surface. Alcon calls it apodized surface. The AMO, or now J&J lens, calls it echelons. And when you have a splitting of light, you lose some of that total light. And so with the Symphony lens, you get a total of about 81% of the full light spectrum in useful vision for distance or up close. A little bit better with the active focus at 87%. This is, asphericity has to do with higher order aberrations and the total spherical aberration. The lens, this one leaves the eye a little bit on the plus side. The asphericity of a cornea is about minus 0.27, so the Symphony kind of neutralizes it. I personally, and doctors feel a different way, I personally think it's better to leave a little bit plus. This, instead of being minus 0.27, is minus 0.2, so this leaves the eye about a plus 0.07, which is a little bit, but I think that helps with contrast sensitivity. That's another reason I use it. The other thing has to do with the add power. So with the Restore lens, it's about a plus 2.5, which sounds like reading, but in the eye, it's intermediate, okay? And it comes to about 21 inches. With the Symphony, it's about 27 inches, 26 inches. And so for me, I think, 21 inches, 26 inches, that 5 inches matters. Mm-hmm. I think a lot of patients, if they're reading out here, that's your computer screen. 21 inches, you're going to pick up a little bit more, or iPad or your phone. But that's just me. A lot of docs have really great outcomes with the Symphony, so I'm not talking down about that. I'm just saying why I like this lens. All right, next slide. The other thing I like has to do with this contrast sensitivity. This is a monofocal lens with a 3 millimeter pupil and a 4.5 millimeter pupil. And they test this on this device called a modulation transfer function machine. And when it shoots lights through there, when you have a larger pupil, the light scatters a little bit with a larger pupil because of spherical aberration. The Restore 2.5, and I can't explain why this is, but it's a little less with a larger pupil. Not the same case with the Technis lens, so it's bigger with that one. So these are just interesting slides for why I think this is the lens that I'm using for now. And this is kind of the latest step to whatever the next big lens is that we have access to. All right, next slide. So let's talk a little bit about astigmatism. Next slide. So how can I have a patient that has, let's say, a half a diopter of astigmatism pre-op, and then they go through their surgery, and then they have 3/4 of a diopter post-op, and I call that a success. How can that be? Doesn't make sense, right? Well, we have different places we can have astigmatism. We can have lenticular astigmatism and corneal astigmatism. Okay, so you can have astigmatism in that lens. And sometimes the astigmatism in the lens is additive to the corneal astigmatism, so that their net astigmatism, when we take out that lens, is going to be the corneal astigmatism minus whatever that lenticular astigmatism is. Or it can be neutralizing. So sometimes they have a net minimal astigmatism, like a half a diopter, but they might have 2 diopters of astigmatism in their cornea and 1.5 in their lens, but it neutralizes, so you have a net of just a half, so that when we take out that lens, all of a sudden they have 2 diopters of astigmatism. And I can't tell you how frustrating that is to patients to think, well, I didn't have this beforehand, why do I have it now? So it's kind of a hard concept, and it's really important to have patients understand it, but it's even more important for you guys to understand it. So you can have a patient that has more astigmatism in their pre-op than they had in the post, and than they have, I'm sorry, I said that backwards, more in their post-op than they had in the pre-op, and it's still successful surgery. So the conversation about astigmatism, you guys, I really want you to understand that. So any questions about lenticular astigmatism and how it can affect corneal astigmatism?
For those folks who are new, can you explain what you're looking for in testing?
So that's a great question. So this is why it's so important that I have either a topographic map from a pentagram or an atlas, or at the very least, auto-Ks or some sort of keratometry readings. And then I can look at the prescription in their glasses, or their AR, or their MR, and I can look at their Ks, and I can tell the patient, I recommend doing astigmatism reducing procedure because of these reasons. And they'll say, well, I don't understand. And then I go through this conversation, and they say, I don't understand. And I go through it again. But it's not too early to have this conversation with them. Okay, so, and you have to understand it to be able to talk to patients about it. Okay, so K readings or pentagram or some sort of, keratometry, measuring device is really important for the doctor to look at. All right, next slide.
Yeah, I was gonna say, and the difference that you're looking at is between the flat K and the steep K.
Exactly.
That's how much astigmatism they
Yeah,
have,
so it's
corneal astigmatism they have.
Simple math. And what this isn't taking into account is there is some potential for influence of posterior corneal astigmatism as opposed to anterior corneal astigmatism. And we have devices that are measuring that, and our formulas, or some of our later formulas, do a little bit better job taking that into account also. So in the ways we treat this are with astigmatic lenses, with LensX, or with limbal relaxing incisions. And then the way we measure that is with the aura reading. So next slide. That's what these lenses look like. Looks like a monofocal lens, but it has an axis in it, so we know where the astigmatism is, so we can rotate that to neutralize the corneal astigmatism. Next slide. So toric lenses, my cutoff, as I had mentioned earlier, is 1.5 diopter of astigmatism. Less than that, I'll typically use a LensX astigmatism LRIs. More than that, I use toric. There's a little wiggle room in there depending on if it's with the rule or against the rule. Did I put that in there? No, that's coming up. With the rule is a little easier to tolerate for a patient than against the rule. Also, it depends on if we're doing a toric multifocal lenses. Multifocal lens, I want to really make sure I have the maximum amount of that controlled. So, if they're going for multifocal, I might be a little more aggressive using a toric multifocal in those patients. And then we talked about, the toric IOL calculator. We do that in the pre-op calculations. It's a must for these patients. And, the patient wants to hear that they are doing well. And I can't tell you how many times I've had a patient come in and they're doing great. How you doing? I'm doing great. I'm seeing great. And they sit down with one of the technicians who's working them out, and they say, oh, you still have some astigmatism. And then by the time they come to me, they are unhappy. So we are not looking for 20/20 with these patients. We're looking for 20 happy. Okay? And it's really, really important that you're telling these patients, you're doing great, everything looks great. And I'm not saying to lie to the patients, okay? But I'm just saying, for the majority of these patients, if there is a little bit of residual refractive error, we can usually do something about it. whether it's a procedure in the office or refractive surgery. But they want to know that they're in the realm of what's normal when you're working out these patients. Next slide. Limbo relaxed incisions. These have been done, I started doing these in, I think, 2002. And, with a blade, as I mentioned. And it can make a difference between a happy patient and unhappy patient. A lot of times I will do this after the fact with these patients. I usually do these Monday afternoons, end of the day. And it can make a big difference for, a little bit of residual astigmatism on these patients. Next slide. And this is how we do it. Have a little eye holder. These have little, spikes in them that kind of prevent rotation. And I use a diamond blade, and I just kind of trace the limbus, with a certain amount of size and depth with these diamond blades. And we don't do this primarily usually these days because they're a little less predictable. So I typically do these just to try to maximize a post-operative outcome. All right, next slide. And again, this is just to remind me to talk about dry eye again. These patients, come in sometimes looking like somebody's taking sandpaper to the front of their eyes. So really, it's really important that they hear about dry eye and our dry climate and things that we can do. And we have a dry eye clinic, and we have, great drops for dry eye. And okay, next slide. I think that's all right. So just a couple last minute. So be a cheerleader for these patients. We're looking for 20 happy. Try to refract to planosphere. Okay, so a lot of these patients, if you they'll eat up some minus, and you'll be refracting, and yeah, maybe it's a little better with -1/2 or -3/4. Well, maybe not. Sometimes these patients, it's easy. Well, it's darker, so darkness sometimes looks like better clarity, but it's not necessarily true to their refraction. So the goal is to get them as close to plano and not over minus because of the patient saying, oh yeah, that's better. Not more clear necessarily, but maybe darker. So yes.
Dr. Smith often discounts the AR for those multifocal patients because of the button that you were talking about earlier. Would you also agree with that? I totally
agree with that.
That the AR isn't gospel in those scenarios?
So you can, that's a really good point. So when these patients come in post-op, they've had a multifocal or a toric lens, you get an AR, and it's going to show all this astigmatism, and you start at that, and then, it's easier to leave them with bigger refraction than what they really need. So better to start with planosphere on these patients, unless there's something grossly different or grossly wrong.
And the symphonies are easy to over minus.
Yeah.
So you should, if you've ever done a crystalline refraction, you know how you always want to leave them plus, which a lot of you guys probably haven't, but you always want to push plus on those, on the symphonies in particular. It's probably where the AR lens is reading them, where the AR refractor is reading them. So.
All right. I think I have just a couple more. Team approach. The night halos do, for the most part, get better over time. We're all part of this, okay? And our outcomes help patients say this is the only place in the state, or at least in Northern Colorado, to get their cataract surgery done. Next slide. Sometimes patients get a little irate in there, okay? And like I earlier mentioned, sometimes you'll hear it and I won't hear it. So it's important just to stay calm, be the grown-up in the room, as they say. If you feel like the patient has a lot of attitude that's directed towards you, excuse yourself, okay? You don't have to, it's not in your job description to put up with that. So there's plenty of other people that are very skilled to deal with those kind of patients. And as you get better and better, you're going to get better at that yourself. So don't feel like you can't remove yourself from any situation. And let me know, let Heather know, or Joanne, or or Savory, or some of the people that have been around the block here a little bit longer.
He's
next
calling
patient.
us old.
And that's it.
Season.
All right, so questions? Yes.
On the toric lenses, is there an upper limit of cylinder correction?
There are.
What-
Yeah, so we use T3 through T9, and T9 plus astigmatism plus a lens X, we can get around 4 diopters, not really well, and you have to be so accurate on the outcome. So, but anything over 4, I'm pretty much telling him you're still going to have refractive astigmatism.
Do you still encourage people, say somebody has 6 diopters, do you still encourage them to get the 4? and
I do.
have just 2?
I absolutely do, and I think,
Relying.
with a lot of these patients, if we can maximize what we can do with a lens, and then oftentimes we can get the rest with LASIK.
Okay.
I could tell you, Dr. Mayer, even with the irregular astigmatism patients, he sees 6, 8, 12 he still tells them, if we can get your astigmatism down, that's a win. So, even in the irregular shapes, he'll tell them it's not gonna be perfect at all, but it'll still hopefully help reduce the astigmatism.
And one comment I have about the multiple focuses is be really, really careful. Don't ever let patients think that they're never gonna wear glasses again. Because one of the things that we hear in pre-op a lot is that I'm never gonna wear glasses again. And I'm gonna invest all this money, and now you're telling me that I'm gonna still have to wear glasses. And they don't understand the 2 out of 3 zones is what they're going to get. And that's a difficult discussion to have with them when they're at the pre-op appointment. And as soon as they say, I'm never gonna wear glasses again, we have to kind of stop and make sure they understand their expectations.
Right.
So,
I always say we are working to reduce your need for glasses.
right. And one thing I really like what I hear Dr. Foster tell patients is we don't know how to do that yet. We don't know how to give you perfect vision. And I think that's kind of a nice thing to say is, I wish I could do that for you. I don't know how to do that. But the best I can do is, to give you 2 out of the 3. So patients hear what they want to hear.
Sure.
But just be real careful how you word that.
And most people, like you said, if you reduce their dependence on glasses, and they can most of the time hold things out just a little farther and see, and just throw in some readers when they're reading for 2 hours at a time.
Right.
They're just tickled pink, most of those folks, for sure. For the season techs in here, what are some of the things that you guys do say when patients are unhappy, or their sister had this happen and they had, perfect vision the minute they woke up from after their start? I mean, what are the types of things that you guys have said to patients to kind of calm the situation, or to?
Well, I tell them every eye is different, every person's different, especially one day post-op. There could be swelling, a little bit of dryness, you're dilated, still maybe a little bit. Just give it time to heal and come around. And
Yeah, you could be 20/20 first day, or you could be 2400 first day.
I often tell patients that, we beat your eye up pretty good yesterday on purpose, but your eye's reacting to that. And even if I'm working with Dr. Smith, I will tell patients, Dr. Olsen, one of our other cataract surgeons, always tells patients, I don't care what your vision is the day after surgery, I just care that the pressure's good and there's no infection. It will get better from that point on. So I think that's a good tool that I've learned by listening to Dr. Olsen when it's scribing.
Yeah.
I think they also need to know, we had a couple today, well, my first eye wasn't like this. My first eye was better, I could see better. My first eye wasn't red, my eye's itchy now. That's normal. It's gonna be, every eye is completely different.
Right.
Your first eye may have no issue because you're so hyped up, you're scared to death about the cataract surgery, you don't know what to expect. But then when you come back for your second eye, you know exactly what to expect. So you're paying attention to absolutely everything.
I always tell patients that happens too, that the first eye was the exception and not the rule. Normal to be blurry the day after, and if you're not, then that's a happy surprise.
That's a
So
good
they
point.
love to hear it's normal, cause then they
Yeah.
kinda relax a little bit,
Yep.
and they're like, okay, so this is okay, this is fine.
Thank you. Any other questions, Dr. Wilson? Now's the time. Did you do surgery on that man?
I did. Both eyes at the same time. Did one and then did the other one.
Wow.
Mhm.
Yeah.
Mhm.
he was happy.
Yeah.
He was sitting up like that cat.
That would be,
Yeah.
that would be 20 happy, that'd be 20 thrilled.
All right, well, thanks for
Thank you, Dr.
listening.
Olsen.
Thank you.
Thank you.
Mm.